Good afternoon, everyone, and thank you for joining our webinar today. We're right at the top of the hour, and so we're going to go ahead and get started. My name is Anna Whiting-Sorrell, and I work for Kaufman and Associates, and I will be your moderator today. This webinar is provided on behalf of the Centers for Medicare and Medicaid Services, the Administration for Community Living, and the Indian Health Service. I would like to welcome everyone to the Long-Term Services and Supports webinar series. Today's webinar is Seasons of Care, Assisting American Indian Elders with Healthcare Access. Before we begin, I would like to highlight the main features of the Zoom webinar interface. So first, the presentation slides will appear in the main window, while the speaker will appear in the top corner. At the bottom of your screen, there is a menu bar. You will here you can find chat, raise your hand, question and answers, and the closed captioning features. Please use the chat box to report any technical issues you may be experiencing. We will respond to these concerns as they come in. Next to the chat box is a raise hand feature you will be able to use during the question and answer segment to let us know if you would like to mute your mic so you could ask a question. And we really encourage questions. And so we hope you will use that, and then we can have you do those verbally as well as in the chat box. Another way to submit a question is in the question and answer box. So chat box for technical issues, question and answer box for the questions, where you leave your questions at any point during the webinar and for the presenters, and we'll answer the questions at the end. Lastly, live captioning is available for today's broadcast. Simply click the CC icon to use this feature. Please know that today's webinar is being recorded, and that recording will be made available online in the near future on cms.gov. And I can see that someone's saying my voice is choppy. I am going to go off camera. I live in rural Montana on a reserve with CSKT, and sometimes my internet, as we all know, can be difficult. And so hopefully that will help. I'd like to also note that the webinar series is supported by a contract by the Centers for Medicare and Medicaid Services. The opinions, findings, conclusions, recommendations expressed in this webinar are those of the presenters and do not necessarily represent the official position or policies of the Department of Health and Human Services or the Centers for Medicare or Medicaid Services. Today's webinar, we are going to look at identify the historic and systemic. Move this around a little bit so I can see better. And we're going to look at, and how that has impacted the healthcare of American Indians. We're going to describe American Indian elders' perspectives on accessing healthcare, and we're going to name at least two feasible and culturally relevant assistance for American Indian elders. So today's webinar presenters, we have three presenters, and I'd like to introduce them. They're from the Pacific Institute for Research and Evaluation. The first one is Dr. Emily Houses. Second, we have Dr. Emily Jaramillo, and then we have our third, Dr. Kathleen Wilgig. And so I am going to just throw that right to Kathleen and look forward to all you have to present. So thank you, Kathleen.
Sure, and I'm going to punt to Emily.
Thanks, Katie. And thanks for the opportunity. Thanks for the opportunity to talk about the work we have been doing with American Indian elders in the Southwest US. We are from the Pacific Institute for Research and Evaluation, which is an independent nonprofit organization that's focused on conducting research that improves the health, safety, and well-being of individuals, communities, and nations around the world. This project was funded by the National Institute on Minority Health and Health Disparities. We're pleased to have the opportunity to talk about using culturally congruent approaches to addressing barriers to healthcare access for American Indian elders. We already went over the objectives, so let's go to the next slide. First, I'd like to talk about historical and systemic conditions that influence healthcare for Native American elders. Understanding the context can help shine a light on much of what we see today when we examine health outcomes in American Indian populations. Now, I looked at the attendee list and I see some familiar faces or familiar names. So this is a pretty well-informed audience. I'm going to go through this pretty quickly, but it's good to just know, and for those who don't know, the policy history of Indigenous peoples in this area that we now call the US can be roughly divided into 5 eras. There's pre-contact, removal, assimilation, termination, and self-determination. And every policy from these eras will have implications for American Indian health today. And I have pre-contact there because so many people who aren't familiar with Indigenous life, Native Americans, sometimes think, or they often think, that this was a barren wasteland before contact. No, that's not true. There were roads and trading and agriculture and territorialism and well-established cities. So going quickly through these eras, we have removal, which was guided by the doctrine of discovery and international law coming from Europe that justified the claiming of sovereign Indigenous lands in the name of Christianity. That then was extended to manifest destiny, saying that it's God's will that the US be inhabited and owned by white Americans, not Indigenous peoples or Black slaves. From that, we have treaties where people were removed from their lands or isolated to certain lands. This is widespread until the 1800s, moving into assimilation. We have the Dawes Act, which parcels out in reservation lands to individual tribal members as a strategy for assimilation. The Snyder Act in 1921 was in response to the poor health seen in Native Americans living on reservations. This also granted citizenship to Native Americans, except for in certain states, of course. With citizenship, then federal funds could be allocated to healthcare needs for Native people. Termination is the next era. In the 1950s, these policies allowed for sale of Native lands to non-Natives. This eroded tribal holdings. Some tribes were derecognized. We also have the Transfer Act, which establishes the IHS, the Indian Health Service. And into the next one, which is self-determination, we have most notably the Indian Healthcare Improvement Act in 1976, which allowed the Indian Health Service to receive reimbursement through Medicare and Medicaid for services, critical for a system that was underfunded from the start. And then in 2010, the Affordable Care Act made the Indian Healthcare Improvement Act no longer subject to partisan politics. Now it's just subject to budget-based partisan politics. It also opened access to Medicaid to a much larger population in states that opted for Medicaid expansion. So it's allowed a massive amount of funding to flow to the Indian Health Service, struggling to meet the most basic patient primary care needs. Of course, there's so much more richness to American Indian history. These are just some key points. Next slide, please. Getting a little more granular, we know that members of federally recognized American Indian tribes have a legal right to health care. It's provided through the Indian Health Service. So American Indians who are members of federally recognized tribes can receive healthcare services at IHS-funded facilities at no cost and without having to be enrolled in health insurance. But I want to make it clear for those who aren't aware that the Indian Health Service is a healthcare provider. It's not health insurance. IHS serves 2.7 million American Indians and Alaska Natives. It also, the budget pays for hospitals, tribally run programs, and urban Indian health clinics. It also pays for purchase referred care, which used to be called contract health service. And it's supposed to cover specialty care not available at an IHS facility, including oncology care, dental, and some diagnostic tests. The problem is that the IHS budget is discretionary, not mandatory. So Congress has to vote to approve the IHS budget every year. There's no requirement that the budget cover all the costs that IHS users need. This is different from programs like Medicaid and Medicare, where payments are guaranteed to anyone who meets the eligibility criteria. And we've heard over and over, you're better off being something than something with IHS funding. You better not get sick before June is one of the things we hear a lot. One of the people that we interviewed for this project, an administrator of the National Advocacy Organization, stated, "You're better off being in a federal penitentiary than on an Indian reservation," because the funding for IHS is so low. IHS receives less money per capita than it does than the people who are federal prisoners receive. IHS does not have a lot of funding earmarked for elder healthcare specifically. One physician who we spoke with said there's no actual dedicated line item funding for elder services or elder care of any sort in the IHS budget. Because of this chronic shortage of funding, IHS users often encounter outdated facilities, shortened service hours, and a lack of doctors, nurses, and other clinicians. For example, in 2016, 23% of essential healthcare positions in the IHS were vacant. Lack of funding also means that the IHS cannot afford to provide comprehensive services, including many of the services that elders need, such as assisted living, long-term care, and home and community-based services. It also means that purchase referred care, the funding that pays for specialty services, has to limit the kinds of services it covers depending on how much funding is available year by year.
So much of what we're presenting today comes from a project we just completed, and it's called the Seasons of Care Study. And throughout the presentation, I'll drop some articles that are open access that are free for you to just peruse and use as you would. And they all come from this study. The research questions of the study were, how do American Indians elders go about getting healthcare, and what are their experiences with healthcare? How do elders understand health insurance, and what are their experiences enrolling in and using health insurance? How do health professionals like outreach workers, healthcare providers and staff, and administrators of health systems and tribal leaders understand the factors affecting insurance and healthcare for elders? And then finally, how do state and national policies like the Affordable Care Act affect services for elders? We presented this study when it was being formulated to 20 tribal communities in the Southwest US, and 8 agreed to take part. Of these, some relied on the IHS for healthcare, and others had assumed either total or partial control of healthcare delivery under the IHS self-governance program. We also included non-reservation urban American Indian communities in the study. Our research can be described as a mixed method, meaning that we collected both quantitative and qualitative data. Quantitative data are about numbers and statistics, while qualitative data focuses on words and stories. In particular, we did surveys with elders to collect information about their healthcare experiences. We also conducted semi-structured interviews to better understand these experiences and hear stories from all our study participants. Finally, we did something called concept mapping, which is a technique for brainstorming and ranking ideas for improving healthcare for elders. With all the information we collected, we designed and piloted a user-friendly guide that's available on the internet. It's a navigation guide. It's intended to provide accurate and up-to-date information that health professionals, elders, and their families can use to help elders navigate healthcare and insurance systems. The whole study has been overseen by a group of American Indian elders and allies called the Seasons of Care Community Action Board. They helped us develop the research instruments and assisted with recruiting participants. They've also given feedback on the results of the study and have helped us interpret and prioritize findings for sharing with others. This research was also conducted with the help of elder consultants who are from the communities in the study. Next slide, please. And I'm going to pass it over to Elise.
Thank you. So now I'm going to talk a little bit about the prominent themes that emerged in the qualitative interviews that we did with elders, specifically around the topics of wellness, how they stay well, and their experiences accessing healthcare. So as part of our Seasons of Care study, we asked elders, what does wellness mean to you? And also, how do you go about staying well in your everyday life? And we really talked in depth about the ways that they stay well and what they feel wellness means to them. So first, I want to talk about some of the individual factors or characteristics that came up when elders talked about wellness. And these included physical, mental, emotional, and spiritual qualities. So first of all, very simply, a lot of elders, when we asked them, what does wellness mean to you? They talked about everyday markers of physical health. The ability to work, the ability to take care of grandchildren, or just being able to kind of get up and around in the morning without too much trouble. So we've included a quotation here from a gentleman that said, wellness, I would say, is just having the ability to get up in the morning and just do stuff and be active. So in addition to these markers of physical health, most elders also associated mental and emotional factors with wellness. So for example, one woman that we've quoted here defined wellness as a mental acceptance of your life and to just be happy. Most of the elders we interviewed described these aspects of wellness as being interconnected. So they explained that wellness was really a balance of physical, mental, emotional, and spiritual health. And many of the elders we spoke to described this concept of balance as being a specifically indigenous and holistic approach to health. Spirituality was an important part of elders' efforts to strike this balance of wellness. For example, one woman that we've quoted here explained, I do a lot of praying and being thankful, praying good and thinking good thoughts. Spirituality also included traditional practices like prayers and songs and participating in feasts and dances. One woman summed up, I do a lot of our tradition because that's important. That's part of how you keep your health. Finally, most elders emphasize positive thoughts and a positive attitude. So here's a quotation from a woman who said, I try to look for the positive in everything in life. And throughout these conversations, elders also stress their own independence as being a particular sign of wellness. So this was a really strong theme that came up throughout the interviews, was the theme of independence as a sign of wellness. So when asked to define wellness, elders spoke about being able to take care of themselves and do things for themselves and not have to ask for help. So one woman said that wellness meant being able to do what I want to do and not worry about elevating my feet or having to stop. And then many valued being able to get by without needing help. So here's a gentleman that said, being well means being able to function like I did 10 years ago without outside help. And he described, sometimes I get my clothes, I fill the bathtub with water and I wash them by hand. A long time ago, I used to do that. And that just makes me feel my worth. And then relatedly, many of the elders that we interviewed also linked wellness to their ability to speak out for themselves about their own needs, especially when they were dealing with doctors or health insurance providers. And at the same time, they also expressed that they were really worried about other elders that they knew who were not able to speak up for themselves. So that was a very common concern, is that there were elders in the community that were not able to speak up for themselves. And they felt that the elders weren't able to speak up for themselves either because they didn't know how or because they were restrained by their circumstances. So here's an example. This woman expressed the importance of speaking up most strongly, saying, wellness is speaking out. It's your duty. My first obligation to myself and to my people is to speak your mind and heart in the Indian way. So we also talked to elders about how they stay well. And again, their thoughts on how they stay well also emphasize these physical, mental, emotional, and spiritual components. So most elders mentioned basic, physical aspects of staying well, trying to keep a healthy diet, some form of exercise, like going for walks or doing chores, like housework or gardening. And then many talked about just the importance of staying active, like this participant who said, all day long, I'm going here and there. Sometimes my husband will tell me, sit down, will you? You make me dizzy because I don't stop all day. Other elders called attention to changes that they had made to their diets to stay healthy. So they talked about eating different foods or paying attention to labels. One woman noted that this could be really difficult for elders, saying, I have to measure food, read labels, and get schooling for diabetes. And so, like the idea of wellness itself, elders really described all these different ways of staying well as being interconnected. So one woman summed this up really well. She said, I walk all the time, walk and pray, walk and pray. My doctors agreed that's the best thing. It's just that time to yourself and you're praying, and I just burn my sweet grass and do my prayers and walk, and I'm here. So in addition to these conversations about wellness, we also talked to elders about the things that made it easy or hard for them to get healthcare. We asked them, what makes it easy or hard for you to get healthcare? And then we also talked to them in detail about their experiences, accessing care, using their health insurance, paying for care. And so we really got a real detailed sense of what it was like to get healthcare for these elders. And they described a number of different factors that make it difficult for them to stay well. And here I'm really just talking about the obstacles that pertain to the kind of the individual elder. And we'll talk about some more obstacles later in the presentation. But many of these obstacles for individual elders centered on uncertainty about, the right thing to do, the kinds of healthcare services that were available to them, the kinds of medications that were available to them, what was covered by their health insurance. There was a lot of uncertainty about these issues that really came up over and over. Both the elders that we spoke with and the health professionals that we spoke with commonly said that they were not sure where to get good, reliable information about healthcare and how to navigate the healthcare system. So one administrator from a healthcare system explained that for elders, especially those who were used to using the NIH for their healthcare needs, knowing that they have this process to contend with insurance coverage and knowing who is paying for what and what they're billing for and what's covered and what's not covered, and buying additional benefits to cover gas and services, sometimes it can be very overwhelming. Another common concern was concern about incurring medical expenses that they didn't know how to handle. And then we also heard from many elders that it was not easy for them to communicate confidently about services that they could get with their healthcare providers and their insurance providers. Participants suggested that elders struggled with the fact that interacting with health systems really required that they advocate strongly for themselves, that was a real obstacle for a lot of elders. So for example, one woman mentioned that when doctors asked her if she had any questions, she said, I don't know enough to ask any questions. That was really a concern for her. And then briefly, in addition to these individual level factors, relationships with family and friends were also important elements when elders talked about their wellness and their ways of staying well and accessing healthcare. So for most elders, family and friends were positive and supportive influences on their wellness. Several of them talked about their children, encouraging them to exercise and eat well. So for one example is this woman who explained, me and my daughter and my grandson go to the gym every morning because I didn't notice myself, but my daughter looked at me and she says, you need to get yourself into the gym. Other elders described being cared for and caring for others as a major component in their wellness. So one woman joked, I exercise by holding my granddaughter. I use her as exercise. And then elders also explained that wellness was learned as part of their family connections. So one woman here that we've quoted related that we were also very fortunate in being around our elders and our older people, and they raised us and taught us different things. One of the things they taught us was how to cope with stress and anxiety and health issues, and it's the way we were raised. And then another man quoted here spoke about a friend of his, explaining that she's teaching young people about right from wrong, having respect for people, having to help other people out. She's teaching them the customs and traditions of the tribe. She's teaching them how to speak Indian. So these sources of knowledge and learning were a major source of wellness for the elders that we spoke with. And then finally, on the topic of family and friends, elders did speak about how the need to care for others was sometimes a burden or a source of stress. So even though elders really valued their relationships and the role of being a caregiver, this was sometimes a burden for them. So one woman explained, I'm going to take care of my kids and my grandkids, but that's my worry at times. And then another major theme that came up was that elders also worried about imposing on their families or being a burden on their families when they had health concerns. So one woman we spoke with explained that this fear of being a burden was the reason that a lot of elders are uncomfortable talking to people about their health issues. So she explained a lot of elders will just say, no, I'm okay, I'm all right, or they don't want to be a burden to their family. So they won't say exactly what's been ailing them for a while. So these are the individual and interpersonal factors that shape elders' experiences of wellness in our research. And then I'm going to pass it over to Emily again here to talk about some of the institutional and community factors.
Thanks, Elise. Most of elders' thoughts on wellness focused on aspects of their personal choices, experiences, and relationships with friends and family. But elders were also critical of many factors pertaining to their communities, healthcare providers and organizations, and tribal, state, and national policy. First, elders told us about several challenges associated with using the IHS. One common theme was the experience of waiting. Elders talked about all the waiting that was involved in scheduling appointments. In the quote here, an elder described the frustrating process that happened if he had to reschedule an appointment. Elders also talked about waiting across their healthcare experiences, including waiting on the phone and waiting in the waiting rooms and the exam rooms. These experiences of waiting for so long and then having a very short visit with the provider made elders feel disrespected and unsure that their needs were being met. Another common experience that many elders shared was the frustration of provider turnover. In general, the elders we interviewed, they liked their providers, they felt well taken care of, but they were frustrated when they kept losing the providers with whom they had formed good, trusting relationships. One elder complained, they're always leaving. When you get to know this one doctor a little better, then they move and you get somebody else. Often their health conditions required care from a specialist outside the IHS system. To be seen, they have to have a referral from their IHS healthcare provider. The process of getting a referral from their IHS healthcare provider was confusing because the IHS system required all referrals to go through the Purchase Referred Care Office, regardless of their insurance provider. So they might have had insurance outside of PRC that would pay for it, but they still had to have the referral go through PRC. We spoke with one elder who described a stressful and hard to understand process that was not adequately explained to him. He said, I have to wait to first get rejected by PRC and then Medicare picks it up. For some reason, I don't know, but they run it through PRC and they should just automatically know they're going to reject me. Or maybe that's the way they go about pursuing other avenues. Other elders described communication issues between the different providers that they had to manage. For example, one elder recounted the difficulties with his referral reaching a specialist. Constant communication issues resulted in the elder being told that he had to hand deliver the necessary paperwork. Now, remember, this is in the late 2010s, okay? As he described, the provider told him, you have to come and get it and take it over. And then the lady at the spine place, she says, how come they won't fax it? She said, every time they fax it, it gets lost. That's why they wanted me to come to the city and get it and take it. I'm going to burn gas going up and down the freeway. Elders also encountered common barriers in their efforts to understand, enroll in, and use health insurance. First, they often expressed frustration with the necessity to engage with technology that was unfamiliar or off-putting. An outreach worker who assisted elders noted that it's becoming increasingly harder for elders to get their questions answered because insurance plans are kind of moving everything technology. An elder we interviewed described her discomfort with automated systems that did not allow her to talk directly to another person, saying, I'm one that will not listen to the recording. I pressed the 0 for operator and I said, I want to talk to a human. I don't want to talk to no recorders. So even if I have to wait for 5 minutes or whatever it takes, I will talk to a human, not a recorder. I can definitely sympathize with that. We also heard from elders that the telephone trees were particularly difficult to navigate if they were hard of hearing or were using rotary phones, which were still in use in many homes. In addition to the challenges presented by technology, elders and others struggled with the complex information, requirements, procedures, and paperwork associated with health insurance. A health system administrator explained how the elders had spent most of their lives receiving care within the IHS and had only been introduced to health insurance very recently. The process of learning about payment and coverage and the language of health insurance is confusing and a burden for elders. This was compounded for many elders by a lack of culturally tailored, trustworthy support for enrolling in health insurance. Once the Affordable Care Act passed, there were many new options, and insurance companies were eager to enroll elders, but they didn't take the time to explain the benefits before enrollment and help with receiving benefits after enrollment. As this benefits coordinator said, it felt very disrespectful. The task of negotiating complex healthcare and health insurance systems also presented challenges to people who work with elders, like outreach workers, healthcare providers, and benefits coordinators. The professionals we spoke with emphasized that they did not necessarily find it much easier to find reliable information than the elders did themselves. Often, the professionals had expertise in one area, like Medicaid enrollment, but they struggled to help elders who had questions about something like Medicare. Many explained that they relied on the strength of relationships and knowledge among the staff in their own agency to find answers to elders' questions. For example, a tribal community health representative, or CHR, described how among our staff, we ask each other how we deal with certain situations. Sometimes we share the numbers, we share names to call a certain individual so that we can get the assistance. Other professionals noted that their ability to help elders came from their personal experience helping family members, like this tribal liaison for a health insurance company, whose knowledge about navigating healthcare and health insurance systems came from helping her own grandmother. However, this individual also noted that when issues arose that she did not have personal experience with, like the problem of Social Security fraud, she did not know how to help. Finally, many of the professionals we interviewed noted that one of their most important roles was helping to communicate cultural information on behalf of elders to healthcare providers who may not be familiar with their cultural values and norms. For example, a tribal CHR described a potential situation when they might have to caution a doctor to be culturally sensitive in the way they communicated with an elder about an amputation. Ultimately, our participants emphasized an urgent need for specific culturally relevant information, resources, and tools to help elders learn about their full range of healthcare and insurance options, overcome financial, cultural, and geographic barriers to healthcare and health insurance, and manage their own healthcare and insurance decisions. Most of elders' thoughts on wellness focused on aspects of their personal choices, experiences, and relationships with friends and family. But elders are also critical of many factors pertaining to their communities, healthcare providers and organizations, and tribal, state, and national policy. One problem that elders mentioned was the shortage of programs that would help many elders stay well, such as treatment for post-traumatic stress among veterans. Others complained about turnover among healthcare providers as a major obstacle to their health. Another influence that elders mentioned was the limited and uncertain funding available to IHS and tribal clinics. They also explained that while tribal leaders cared about their health and their well-being, they also had many other competing priorities that meant that they couldn't focus on elder health as much as they might want to. Ultimately, many elders and others who we interviewed expressed the conviction that the struggles elders experienced in navigating underfunded IHS facilities and the complex healthcare systems were rooted in the invisibility of elders in local, state, and federal policy. One man commented, "As Native people, we are ignored." Elders felt neglected by policymakers, a perception shared by their allies. The administrator we quoted earlier commented, "Our leaders in Washington, D.C. have no idea that American Indians are even alive in this country, and they don't have any idea as to the vastness of our communities and the struggles and trials of our communities as a whole or as separate tribes." We learned from our conversations with elders that wellness is a complex topic that involves many different factors. Most importantly, elders emphasize their own physical, mental, emotional, and spiritual health. Second, they pointed to relationships with family and friends, but we also learned that factors involving healthcare institutions, communities, and policies were influences on their health. These different levels interact. The interactions sometimes benefit their wellness. For example, being a caregiver, those family and close relations, contributes to feelings of independence and well-being among elders, the individual. Tribal leaders' awareness of elder health issues, the community, helps to make elder health a priority in their local health systems, the institutions. National policy can create resources for local health systems, institutions, and that improves elders' access to healthcare, the individual. So it all ties together. I'll pass this over to Katie.
So all of these challenges can be very overwhelming. But to conclude, we want to share some concrete steps that elders, families, and others can do to help elders by making their needs, values, and desires more visible in healthcare encounters and in local, state, and national policy. First, elders and their families can practice advocating for themselves in healthcare settings, meaning speaking up for what they want and need, even when it might be uncomfortable to do so. Family members can empower elders by accompanying them to their appointments to help them remember information and questions to ask, while being careful to respect their privacy and their independence to make their own decisions. Elders should be encouraged to ask a lot of questions about healthcare and insurance and to request help when they need it. Many of the elders we interviewed prided themselves on their assertiveness. Elders like these can help their peers to speak up and voice their questions and concerns as well. Health providers can also take steps to make elders more visible in healthcare settings. They can prioritize building trust and rapport with elders so they feel comfortable and cared for. Providers should commit to long-term service in a community so they can develop strong relationships with their elder patients. They should also try to learn as much as they can about their local environment, including the specific needs of local elders and the resources that might be available to them. And providers should not assume that elders will speak up, but should take the time to ask them if they have questions and take the time to answer thoroughly and in the language that elders can understand. In addition to these individual efforts, elders and their families can work with healthcare administrators to advocate for systems change, such as greater investments in workforce and services that elders need, including ancillary services like physical therapy and prevention services. Other important system change centers on support for elders, such as interpretation or staff to answer the phones. And healthcare administrators can advocate for changes to the way that appointments are scheduled and how providers are assigned to minimize waiting and turnover. Administrators of health systems should also prioritize learning about and helping elders to access resources that are available locally in their communities and states. Tribal leaders also have important roles to play in making elders a priority. First, they should educate themselves about healthcare and insurance so that they understand elders' concerns and struggles. They can also conduct needs assessments of their local community to get a clearer sense of elders' needs. Third, although tribal leaders have lots of competing demands, they can work to increase continuity between administrations so that efforts to help elders are carried across from one leader to another. And this was one of the biggest implementation gaps that we encountered when there was a change in the tribal administration. So initiatives that might have been started to, benefit elder health could be discontinued when someone else was in office, and there were those competing demands. Fourth, they can work to develop and use tribal resources to provide support services for elders and their families, such as benefits coordinators. And many of the tribes we were working with did have benefits coordinators. And again, this was a service that they subsidized. They can also work with their local IHS or tribally run programs to better integrate healthcare services with other resources that are available in the community. And finally, they can prioritize efforts to highlight the needs and experiences of elders by supporting programs that engage elders in their communities. And finally, we can all advocate that policymakers learn about American Indians and the policies that affect them and take steps to improve the funding and service environments for elders. These improvements could include dedicating resources to navigation services for elders to help them move through healthcare and insurance systems more smoothly, ensuring line item funding for long-term services and supportive resources for elders, and providing technical assistance to tribes to help them apply for additional funding and administer their own local healthcare systems. Such technical assistance should be tailored to tribes and thus informed by the perspectives of the end users, meaning elders. And policy makers should also work towards bigger picture changes. First and foremost, they should advocate for full and mandatory funding of the Indian health system by Congress. They can also push for changes to the way that healthcare and insurance systems are run to make them simpler and easier to use, such as automatic enrollment and re-enrollment and universal networks that allow elders to get care wherever they prefer. And lastly, we can all encourage and support elders and their supporters to win elected office to shed greater light on elders' experiences. So I want to give a big shout out to all our research partners and to our Community Action Board. A special shout out to Dr. Ron Lujan. He was a surgeon from Taos Pueblo, and he really made this study possible. It was at his urging that we brought together our Community Action Board, and they really helped us plan this work and implement it successfully. Thank you all for attending our presentation today. And if anybody'd like further information about our study, you can contact me or Emily or Elise. And again, feel free to peruse our publications and drop us an email if you have any questions. Thank you. I think we're good for questions now.
All right, so are we going to move to the next slide, the question and answer slide? I have been monitoring the question and answer box, and it doesn't look like there's any specific questions, some good information in there. Just recently, Rosie put in, will there be a recording of this presentation? And the answer is yes, and it'll be put on. I want to be clear that it goes on cms.gov, and so you'll be able to find that recording there. So are there any questions? If you have a question and you want to raise your hand, you'll be able to, we'll unmute you and you can ask the question that way, or you can put it in the question and answer box. So while we're waiting, one of the questions that, as I was listening to you recently, the most recent budget for IHS has allowed for a little bit of advanced funding, and I'm not quite sure what all that means, but if any of you do, I think that's it's a real big step forward.
Yeah, the most recent budget, which was approved, it hasn't been totally approved, but it does allow for advanced appropriations, and it also has some funding for elder care. So it's a huge step forward for us. We have to wait until the ink is dry before we can really celebrate, because these things, we can always get excited about what people are proposing, but until we actually see the money come, it doesn't mean anything. And I've been disappointed before, but we just have to keep educating our lawmakers to support Indian health at every level, and hopefully we'll get what we need.
Yeah, thank you, Emily, for that. And as we look forward, I know that the IHS agency director really highlighted that in her recap of the year. So I think there's a lot of good things that we might be seeing in the near future around that. And so one of the questions is, could you talk a little bit more about the role of your Community Action Board in your study? And also one of the questions was, what were the ages of elder? I mean, I know sometimes there's different ages when people are considered elders. So if both of those questions could go to somebody.
So Elise, do you remember what the upper age limit was?
The upper age limit, I think we spoke to somebody who was maybe 88. I think that was probably the oldest person that we spoke with. And it was 55 and above. And we chose those that age cutoff because even though 65 and above is the cutoff for Medicare, the slightly younger age limit accounts for, you know, some of the impacts on life expectancy among American Indian folks. So we chose a slightly younger age cutoff there. And we did do some interesting analyses. One of the articles that Katie posted in the chat there talks about differences between elders who are 55 to 64 and elders who are 65 plus. So there are some interesting differences in their experiences. And one of those being, sorry, not to, but I also see this question here in the Q&A about applying for Medicare, and that's one of those important differences, is that elders who are not 65 yet have a lot of the same needs as older elders, but have less resources available to them because they don't have access to Medicare. So that's an issue that came up.
And the question about your community action board?
Sure, I'll field that question, and then Elise and Emily can chime in. So I mentioned the late Dr. Ron Lujan. He was, you know, a tireless advocate on behalf of elder health in the state of New Mexico, and this is really when the Affordable Care Act was coming fully online, and we were having a new Medicaid system introduced, a new managed care system, and he was deeply concerned about you know, making sure that elders were not lost in the fray. And he really wanted to bring attention to the experiences of elders in healthcare systems. And he brought together this marvelous group of elders who really helped plan this project from the get-go. They helped formulate our overarching research questions. They provided feedback into all the data collection instruments. They were involved in helping us develop and implemented training for elder consultants who they helped recruit. And these elder consultants were from the communities we were working in. And they would accompany us on all our data collection outings. And, you know, they would be collecting the data with us. They would be advising on etiquette. They would be helping with just introducing the study to local folks and helping to build that trust. And they were just absolutely essential to carrying out this work. You know, once we had the data, the elder board, which would meet monthly to bi-monthly, we tended to meet bi-monthly during the pandemic, but they would provide, you know, input into all the findings. So we would put together PowerPoint presentations, user-friendly PowerPoint presentations, and we'd have questions to kind of, you know, elicit their interpretations of what we were finding. I can say that our elders that just had so many brilliant ideas to share. And one thing that I just remember from our last number of meetings is, you know, they really want to see change. They just don't want the disparities documented. They want something done about these disparities sooner than later. There's a real sense of urgency there. And, you know, we're definitely, that message is loud and clear with, you know, each meeting we've been having. And I think it's just been intensified by the pandemic and the disproportionate impacts that the pandemic had on tribal communities. And Elise or Emily, I don't know if you want to add anything, but we couldn't have done this work without them.
No, they're a treasured part of our lives.
I really like your comment, Kathleen, about their sense of urgency and how that was heightened during the pandemic around healthcare for American Indians and certainly our tribal elders. We do have another question in the question and answer box, and there is a woman that works for a nonprofit in Wisconsin, and it is one of the Wisconsin's 8 independent living centers. And her role is 100% to assist folks to stay safely in their homes as long as possible. She's asking about how would you recommend a nonprofit might reach out to tribal agencies in the counties so she's a non-tribal entity, but she wants to reach out to the tribal entities to help, so that she can engage them in their services.
I can take this question. So aging in place is a real strong priority in American Indian communities. And this is obviously, you are connecting very closely with what I think a lot of tribal folks want. Remember that tribal communities are their own governments, their own cultures, in a way, their own communities. So you want to respect that sovereignty. With that in mind, you can approach the tribal government and talk to them about what you're doing. You can also be aware that most tribal communities have their own senior centers and healthcare systems. And so going through that, approaching the senior centers would be a good way to start. But being aware that you have to respect tribal sovereignty and not expect to just walk in and do whatever you want, but go through channels.
Thank you, Emily. That really does make sense. I appreciate that. We do have a question around how will this research continue? So is there, seems like there's been some steps for positive impact, and do you have any ideas about how you'll continue?
Well, I can say, and Elise, maybe you can chime in, but our community advisory board really want us to look at long-term services. So the next project we've been conceptualizing is, what does the de facto system for long-term services look like in many tribal communities? Because it is different, and there's a lot of uniqueness. And so that's a project we're starting to conceptualize now. Elise, did you want to add anything, or Emily?
Sure. I think, this study, brought up as many questions as it answered in many ways in terms of what do we need to look at more. I think that, as Katie mentioned, the landscape of long-term care is a big question mark. I think another thing that we really learned is how different communities are in terms of what's available to them just geographically, the histories of the facilities that are available to them. Some places people really like their IHS, some places people don't. It's very, very specific to different communities. And so what change looks like can be, it was probably different in different communities, even though there are, massive systemic changes that are needed for all communities. So I think another thing that came up for us that would be a next step is really thinking about what does the process of making change entail? Who are the power centers? Who do you reach out to? How do you actually influence those people that are in power? I think that's a big task, because we can point out what's wrong and hope to get to influential people. And that's one of the things that we're trying to do. But I think really buckling down and thinking about, how does change actually happen is going to be an important next step.
And along those lines, I'm thinking bringing in some implementation science perspectives. So how do you make change? How do you, facilitate collaboration across all these different community entities, and what are the implementation strategies there to make sustainable change. But that's also my kind of like personal interest, that I'd like to see implementation science introduced into this realm.
Absolutely, thank you. We have a question about wondering if elders on reservations or not urban Indians, are they eligible to apply for Medicare, and are they able to receive those full benefits? The next question also goes into the insurance marketplace. So if someone wants to talk about both of those as we get close to the end of our time here. So eligibility of elders for Medicare and the insurance marketplace.
Yes, the answer is yes. We are American citizens. If you're over the age of 65, you do qualify for Medicare if you meet the eligibility criteria. For American Indians who live in states that offer the Medicaid exchange, that's the language, right? And you qualify, you can receive Medicaid. So there are no limit, there's nothing preventing people from receiving benefits that you would receive as an American citizen. So just remember, as I said in the beginning, the Indian Health Service is a healthcare provider. It's not health insurance, and it doesn't keep anybody from receiving anything else. I hope that clarifies that question.
Again, so Medicare and Medicaid are federally funded programs, and American Indians are eligible. The insurance marketplace, I believe, if after you turn 65, you're no longer eligible for insurance marketplace, you're required to go to Medicare. Or if your state has expanded Medicaid and you meet those criteria, you're then eligible to be duly covered by Medicare and Medicaid.
And tribes often have benefits coordinators. The Indian Health Service has benefits coordinators. So there are people you can work with to get access to those. And there are special dispensations or whatever, special provisions for American Indians to get dialed into Medicaid. So there really shouldn't be any reason why an American Indian is not insured in this country. That's all I'm going to say.
I will just add, though, if you live in a Medicaid expansion state, advocate for people to sign up for Medicaid, because we definitely saw that healthcare facilities benefited when they had more people covered by Medicaid, and that helped them, develop and shore up their services and to provide higher quality of care. So I'm a big fan of Medicaid when people can sign up for it.
Oh, absolutely. And it is such a way to really get additional dollars into the complex Indian healthcare delivery system. There are other questions. I am so excited. I want to say to our three presenters that I've been moderating these panels or these webinars for a while, and the extent of questions was amazing. You stimulated so much thought and provoked ideas. So I so appreciate your presentation and the questions the participants have added. So I just have a great big, warm, heartfelt thank you to everybody that participated. Someone did suggest that to remind people to go to their local SHIP that can help elders and family caregivers learn more about Medicare, and you can go to www.shiphelp.org. And I think most states do have SHIP programs, and it's just a really good idea on how to do that and get generic information. But because it's state by state, it really does apply, and you can get good information about that using your local SHIP. So with that, I would like to just once again thank everyone for participating. I want to again give my heartfelt thanks to Emily, Elise, and Kathleen for joining us today, and your whole project on Seasons of Care. In closing, I would like to remind everyone that today's webinar was recorded and the audio and presentation slides will be made available online at cms.gov. And so with that, I thank everyone for joining our webinar today. And I just say thank you. Have a great day. And I'm look forward to seeing you at our webinar next month. So thank you, everyone.
Thanks.
Thank you.